Well, hello everyone. Such a pleasure to have you join us at this number 5 of the HIV and Adolescence Month. My name is Linda Gale Becker and I come to you from Cape Town, from the Desmond Tutu HIV Centre. And I'm really thrilled to have you join us. I hope some of you have made 100% attendance so far. If not, and this is your first, welcome. It's really lovely to have you join us. And now I'm going to hand over to my wonderful co-moderator. I'm so glad to have Phyllis Mavushi here with us from Zim. Phyllis, won't you introduce yourself?
Okay, hi everyone. Thank you so much for being here with us in this new era where we do things the new way, and we're doing it virtually, but we're so connected than ever before. So we're going to have a very lively and interactive session on relationships with pills and injections. My name is Phyllis Mabushe from Africa, Zimbabwe. I'm a young person living with HIV, and I'm working at Africa Trandiri, supporting children, adolescents, and young people living with HIV in my country. So feel free to interact, feel free to ask questions and to learn. Thank you so much. I hand over back to you, Linda.
Thanks, Phyllis. And quite right. This afternoon, we're going to be discussing pills, injections, and of course, how we feel about those biomedical interventions that we need, that we use to keep ourselves healthy, to keep ourselves free of disease, to manage various situations in our everyday lives. And of course, we have ups and downs with those very things. And that's what this afternoon session is all about, either for treatment or prevention, the impact of having to think about taking these medications maybe even every day of our lives. And to start us off, I'm absolutely thrilled that we have a keynote speaker of note. It's my pleasure to introduce this afternoon Dr. Alison Agwu, who comes to us from Johns Hopkins School of Medicine in the United States. I know she's been very busy. All of you probably know that the states are very busy with their own COVID epidemic at the moment. So we thank Alison for joining us and for putting this talk together. Dr. Agwu is the Associate Professor of Adult and Pediatric Infectious Diseases. Both her clinical care and NIH-funded research focus is on deciphering health disparities, optimizing care, treatment strategies, management approaches, including access to novel strategies for young people living with HIV. She serves on the board of directors for the HIV Medicine Association, where she continuously advocates for the unique needs of young people. And I know she's an ally in this as we work hard to ensure that there are tailored and differentiated services for young people today. So without further ado, I'm going to hand over to Alison to ask her to make her keynote address.
Thank you to the organizers for having me here today to talk about the relationship with pills and injections, friend or foe, biomedical interventions for prevention and treatment. These are my disclosures. Objectives today are threefold. First, to briefly review the worldwide epidemiology of adolescents and young adults, to discuss unique challenges with biomedical interventions for prevention of HIV for at-risk adolescents and for treatment of adolescents with HIV infection, and to highlight opportunities and obligations to conduct drug development trials in adolescents. A quick disclaimer, there's no way to cover everything, but I will do my best in these 15 minutes or less. So first, let's talk about epidemiology. So globally, adolescents and young adults, 10 to 19 years of age, make up about 16% of the global population of 1.2 billion in this age range. And that's out of about 8 billion individuals. And when you look at this pie chart here, it shows you that about half of these adolescents are in South Asia or East Asia and Pacific, with in the black and gray, another significant proportion in West and East and Southern Africa, and then Latin America and the Caribbean, with a sliver being in North America and in Europe where I reside. When you add the 20 to 24-year-olds, there are another 624 million individuals in that age range, or another 8% of the global population. So in total, 1.82 billion between the ages of 10 to 24, or 30% of the population, are adolescents and young adults. So it's a real force to be reckoned with and considered. When you look at the proportion of populations that are represented in this age range, we're looking at about a third, 25 to 30%, when you add, again, the 10 to 19 and 2020. I always like to go through this slide to talk about risky behavior, which we always hear ascribed to adolescence. And it's a term that I don't like to use because I think the things that we think about in adolescence are, one, a period of significant growth biologically and physiologic changes as represented on the graphic in the bottom. But it's also a period of evolution of cognitive development. Adolescents go from concrete thinking to more complex thinking. They do have a limited perception of consequences. But if they do see the consequences, they're less likely to care about those consequences, right? Because they're more likely to take risk and explore. It's important for building their self-esteem, their confidence, their self-identity, but also important for autonomy and peer acceptance and respect. And psychosocially, adolescence is a period of feeling invincible and independence seeking. And at the same time, parental supervision is decreasing. So it is both. These explorations, et cetera, that are often deemed risky behavior are actually a part of normal development for adolescents. Really important now to think about the major issues that our world is facing: environmental issues, political issues, poverty, racism. Really across the globe, we are in a period of turmoil. And adolescents are there pushing us to be better, asking us to be better, and in some places demanding us to be better. Here comes the risky part of that. So as they explore, as they push, adolescents are at risk for adverse effects or events related to their exploration, et cetera. Things like road injuries, drownings, interpersonal violence, self-harm, and yes, HIV/AIDS. On the left and red are for females, and on the right and blue are for males. And when you think about HIV/AIDS specifically, there are about 4,500 new infections thought to occur every day in the world, and about 40% of them occur in individuals between the ages of 15 to 24, with a predominance among young women. There are thought to be about 4 million young people between the ages of 15 to 24 who are living with HIV, and this data is a little bit old, but thought to be about 60,000 new infections among young people. So when it comes to HIV, there's a positive and there's a negative. In the sense, when one is tested, there's positive and negative, and there are actions to do this regardless of what that test is. First, let's go with the negative test. So with negative tests, your goal is to keep that adolescent negative. So there's a slew of other interventions, behavioral interventions, condoms, etc. Currently, I'm going to focus on pre-exposure prophylaxis, or the biomedical intervention that we oftentimes think about in terms of keeping adolescents negative. So what is pre-exposure prophylaxis? So pre-exposure prophylaxis is a pill, one pill, a combination of two medicines, emtricitabine and tenofovir, when taken together daily, and I'll get to the asterisks because there's some alternate schedules also that have been shown to be effective, but when taken together daily in that one pill format, it has been shown to be 96 to 99% effective in preventing HIV infections. And this has been shown in men who have sex with men. It's been shown in heterosexual women and persons who inject drugs, and is FDA approved in the US, and WHO and other organizations recommended for HIV prevention. I want to be clear that there's the emtricitabine and tenofovir that's been approved regardless of gender, but Descovy, which is a brand name, or tenofovir alafenamide, and emtricitabine is only approved for individuals who are not born with a vagina. But the pill is just part of it. So let's go through what they call the HIV prevention continuum. And that includes when one has a negative test, there's some counseling and some risk stratification that should happen. There's provision of other and tailored services, which may include the PrEP, along with the other things that go into the prevention toolkit that I mentioned, condoms, counseling, etc. And then there's a goal when someone starts on PrEP or is engaged in these prevention practices to retain individuals in care and then support them in adhering to PrEP so they can continue to to maintain their prevention toolkit. When somebody is positive, they go on the life of the HIV continuum of care. And so what that looks like is from diagnosis, the goal is to get the individual into care, a healthcare provider or a clinic, et cetera, and then get that individual as soon as possible started on HIV treatment. And then they go into a cycle. So the goal is to take their medicines every day, to see their healthcare provider regularly, which includes taking lab tests and engaging in psychosocial support, et cetera, taking care of their physical and mental health. And ultimately, the main goal is to keep your viral load undetectable so that one does not progress to decline in your own health, but also does not transmit HIV infection. This chart represents all of the oral medications that we have available in the US. I recognize that there are differences in other parts of the world in terms of what's available, but these are all the multiple medications that are available to create a regimen for antiretroviral treatment for individuals who are living with HIV. In the past, it was a handful of medicines that somebody would have to take a couple times a day, and then ultimately one time a day. But now, the first line regimens are one pill, one time a day for people who are treatment naive, and even individuals who have been on HIV treatment for a while and have been positive for a while. And for the first time, really in the past few years, you can also give them limited numbers of pills, including one pill, depending on their resistance. There's been a major goal to simplify treatment. I already talked about fewer pills, so combination pills when possible, one pill regimens, but smaller pills. It's oftentimes amazing to me that even grown adults have difficulty swallowing pills, particularly if they're large. Fewer drugs. So not just one pill, but fewer drugs inside that one pill that decreases your risk of longitudinal side effects related to more pills and may decrease toxicity long term. The regimens, there's been an effort to have fewer drug-drug interaction, fewer side effects and toxicities, as mentioned, and fewer dietary requirements, meaning not having to take the medication with food or other things that improve their uptake, for example. And studies have shown that head-to-head, these simpler regimens are just as potent. Studies in adolescents have shown that adolescents definitely prefer one pill options than multiple pill options, but still have challenges with adherence, which we'll talk about. Whether positive or negative, prevention or treatment, adherence is the holy grail. There are benefits of adherence, so sustained viral suppression, reduced risk of drug resistance, better overall health, improved quality of life, decreased risk of HIV transmission if you're positive. And then if you're negative and taking PrEP, again, better overall health, quality of life, decreased stressors about acquiring HIV, and decreased risk of acquiring HIV. So it's a friend with benefits. There are challenges. So this is data from ATN 113, which was a demonstration project for PrEP, or tenofovir plus emtricitabine, in adolescents aged 15 to 17. It was done exclusively in young men who have sex with men and looked at acceptability, use, adherence, and drug exposure by looking at hair levels, and then looked at patterns of sexual behavior. It's noted that there are 3 HIV seroconversions, meaning people acquired HIV during that trial, and some of the investigations were to look at what was happening in terms of adherence over time, and also in those individuals who converted. So what you see in this graphic here is on the y-axis is a level of drug in the system, and that black line shows protective level. And what you see over time, individuals were protected mostly, or in near that range, and then over time, things declined, or levels declined, correlating with decreased risk, or decreased adherence level, decreased levels of drug, and then increased risk of HIV acquisition. So you say, what do we learn from ATN 113, the specific study looking at youth? Well, there are common reasons for non-adherence, and they were away from home, too busy, forgot, there was a change in routine, multifactorial. Creative designs were done, trying to remind buddies, parent networks, incentives were things that were thought about and used and may be considered in promoting adherence for young people. Really thinking about the number of visits that young people may need and is more better for promoting adherence. As you saw in that graphic, as time went on, and actually I didn't say this, but visit frequency went extended out, were they less likely to get that reinforcement for adherence? When we're thinking about PrEP and how PrEP would be used for young people, thinking about real world application. Is it something that someone can do every day, and how will they do it? What is the support staff and the things and tools that people need to implement PrEP and to keep it going? And what are the objective markers of adherence? In this study, it was hair, so cutting a piece of hair and looking at the levels. How can we actually tell that people are being adherent? And we need to be thinking prospectively and thinking multidisciplinary, not just the biomedical, but the psychosocial and the other things that need to be in place to support adherence. In terms of HIV, there's a continuum of care for youth with HIV as well. Now, in the sort of turquoise bars is what we see is the continuum of care for adults. Let's start there first. So this is the US population. And if we say this starts with the number of people who are infected, recognizing that only about 80% of adults who are living with HIV are diagnosed and know their infection. Then a lower proportion of those are engaged in care, lower yet prescribed ART, lower yet suppressed their viral load, and then stay suppressed is a number that we oftentimes don't get a good sense of. But if you look next to them, the pediatric or the youth with HIV at every step up the continuum have lower levels, where it's estimated about 6% of youth living with HIV in the US are actually suppressed. And in terms of staying suppressed, even more challenging. So that's where we are. When we ask adolescents why they're not adherent, there's a multitude of reasons why they report being adherent. As you see, forgot was the biggest proportion of adolescents, about 63%. But you see, it's travel, stigma, pill burden. They fell asleep. It was a long way to travel to come to pick up their medicines. There's a change in the routine, and when something was no longer happening the way it was supposed to happen, they were more likely to forget. Palatability, how it tasted, how difficult it was to swallow it. Being busy. Oh, I drank a glass of wine. I therefore was either slept through my medicine or didn't want to take it. Depression, feeling good, and so not feeling like they needed to take their medicine. And then running out of pills were all reasons. So what are we missing? I told you we have fewer pills. We have 1 pill a day. What are we missing? Why not just take your medicine, which is what I've heard plenty of times when I talk about adolescents. Life is dynamic. Adherence is hard, and it's multifactorial. Side effects can be challenging. One side effect may be too much for somebody. Long-term toxicity, and people worry about their bones, their kidneys, longitudinally. The limited choices. I showed you all those choices, but if so many of them are not palatable to you, or in the case of individuals who are treatment experienced and may have resistance or just tired of medicines, or what you call treatment fatigue, the choices are not enough. One size does not fit all, so pills may not be what we need for everyone, and forever is a long time. Disclosure, we talked about changing routine, or changing where you live, and all of a sudden you live with somebody who doesn't know your diagnosis and you're worried about them finding you out. Mental health, and then feeling fine. And lastly, I like you, Dr. Agu, but I just don't want to be here in your clinic or here even thinking about this. So this comes down to, what do we need to do to increase choice, increase options, increase choice, increase options, because one size does not fit all. Pills does not fit all. So that's why we are here talking about this. So simplifying treatment, yes, but are pills even needed? And so pills, you have your friend, you have your enemy. Pills are somewhat of a frenemy. You like them, but you hate them because of the things that we mentioned in the prior slides. So can we find another friend? And can we hit that friend with the bus? All right, let's keep going. So when we talk about injections, this is a study done by Ethel Weld, who's a fantastic young, previously postdoc, who now is faculty at Hopkins, who did a survey of youth's interest in long-acting antiretroviral treatment. In this case, an intramuscular injection or long-acting antiretroviral agent. She looked at 303 youth, ages 13 to 24, that was seen across 4 US clinics in Baltimore, Atlanta, and Memphis, Tennessee. The large majority were Black or African American, with 8% Latino. 74%, so about 3/4 of them, were non-perennially acquired, meaning they acquired their HIV during adolescence. And there was a nice spread, about 10% in the 13 to 16-year-old range, 32% 17 to 20-year-olds, and then the rest in the 21 to 24-year-old range. 60% were virally suppressed, meaning 40% did not have viral suppression at the time they took the survey. When you look at the different clinical sites that were included, there was a high level of interest in intramuscular or IM, long-acting antiretroviral therapy, across the sites. When you looked at how likely people were to be interested in intramuscular injections, their interest increased the more you spaced those out. So you said once a week, about 50% were okay. You got to once every 2 weeks, you got people interested a little bit more. By the time you got to once every month, you really got people's interest. And then that increased slightly more to about 90% for once every 3 months. So it's clear that injectables were of interest, and spacing them out really made people excited. When you looked at viral load and you correlated viral load with your interest in having an injectable agent, what you see is if individuals had an undetectable viral load in the orange, they definitely would be interested or probably would. So you have about 2/3 interested. Compared to those with a high detectable viral loads, they were really viremic. So here, less than 20, here 20 to 1,000, and here over 1,000 in terms of copies per ml. That's where you got the highest interest. So the ones with the most challenge with adherence were the most interested in the injectable. So what is the injectable, you say, Dr. Agu? These are studies from data from LATTE 2, which is the first study that came out looking at injectable cabotegravir and rilpivirine given as a 2-shot regimen. And these were the 96-week results. In this study, they compared 4 weeks to 8 weeks of injectable cabotegravir, rilpivirine. Individuals were treatment naive, meaning they were HIV positive, but had not been initiated on antiretroviral therapy. The study was done in the US, Canada, Spain, France, and Germany. Individuals were randomized to either oral therapy completely, or to cabotegravir, rilpivirine, which they started on with the first an oral period to make sure they tolerated the drug, as well as to make sure they didn't have any drug reactions to it. And then they were transitioned to an injectable version every 4 weeks or 8 weeks. And what you see in this slide here is what you call the money slide, where the virologic response in the every 4-week arm was comparable to the every 8-week arms, which was comparable to the oral therapy. So they had comparable results, and one would say they were not statistically significantly different, but the highest percentage was in the every 8-week arm, which goes along with what the youth said. But interestingly, when you looked at how satisfied individuals were, what you see here in the pink and the blue is the pink is very satisfied, and the green would be not satisfied at all. And so every 4 weeks, you saw high satisfaction for with the injectables, more than you did for the oral. When you looked at how satisfied they were to continue their present form of treatment, again, they were less satisfied in continuing oral, but you saw lots of satisfaction with the injectable. And this just satisfaction, greater in the injectable arms, no matter what satisfaction question you asked. So you asked about injectable PrEP. I knew you did. So injectable PrEP, HPTN 083 looked at cabotegravir, not rilpivirine this time, just cabotegravir as potential regimen for prevention in about 4,600. We're going to start this slide again. So you asked about injectable PrEP. Yes, I was about to tell you. HPTN 083 looked at cabotegravir as an injection for prevention of HIV, so PrEP. 4,600 HIV negative men over the age of 18, cisgender and transgender women. So cisgender men and transgender women making up about 12% of the population that was included. 2/3 was under the age of 30, which is an incredible feat for a study like this. There were 2 arms. There was the arm A, cabotegravir injectable, plus a daily oral tenofovir FTC placebo. And cabotegravir here was given every 8 weeks. Arm B, daily oral tenofovir FTC daily oral, and intramuscular cabotegravir placebo, so a fake one, every 8 weeks. So double-blinded, nobody knew what they were taking. And when they looked at HIV acquisitions in the two arms, 50 overall acquired HIV, 12 of them in the injectable arm, and 38 in the arm with oral therapy. Only 2% stopped due to pain or discomfort with the injections. These are the study sites over here with the US, South Africa, Asia, South America. But the results were amazing, as you see, and leading Rafi Landowitz, the protocol chair, to say that this has the potential to transform the landscape of HIV prevention for cisgender MSM and transgender women. So you say, well, what about women? Injectable PrEP for women, HPTN 084 was conducted in 3,223 women between the ages of 18 to 45 in 20 sites in 7 countries in sub-Saharan Africa, and you see those listed here. There were 2 arms, just like in the MSM and transgender study 083. Arm A was cabotegravir and intramuscular versus an oral placebo, and Arm B, daily oral tenofovir FTC and placebo injection. In this study, 38 women acquired HIV, and like in the 083 study, 4 in Arm A, the injectable study, and 34 in Arm B. This led the Data Safety Monitoring Board to stop the study early. And then the WHO, in releasing the results on November 9th and commenting on it, essentially said it is encouraging to learn that a long-acting injectable PrEP option has been shown to be highly effective in women, and CAB-LA has the potential to increase choice and overcome some of the barriers related to adherence for long-term use of biomedical HIV prevention that we talked about on prior slides. I don't want you to think that there are no more questions. There are some unresolved questions. So for one, what about those less than 18 years of age? What about pregnant women? We know that's a period of high risk for HIV acquisition. How exactly is this going to work in the real world and outside of the clinical space? What will be the risk of resistance if people don't come back to get their next shot and then get HIV? This is actually a really critical piece, because we know that while the drug lasts 8 weeks and the repeat injections are given every 8 weeks, we know that if you don't get that repeat injection in 8 weeks, the drug levels sort of persist and fall over time, right? But the idea, the concern is that it may be in your system for months, longer for women than for men, but at levels that are not high enough to protect you against HIV, but that worry people that if you acquire HIV in that time frame, there may be resistance that happens. So studies are pending to address this. Will it be cost effective? And ultimately, who will pay? So what does the future of treatment and prevention look like? So what's next? It is really multimodal biomedical strategies and approaches. So there's different drugs. There are not just antiretroviral treatments that like tenofovir and FTC that we're talking about, but even longer acting agents that can be taken orally or are coming to study, regimens that can be studied too, that can be given once a month, potentially even longer orally, that are again coming to clinical trials. So different drugs, different modes of delivery. There are rings for prevention, implantables potentially for prevention and treatment. We've talked about injectables, and then non-ART strategies, antibodies, neutralizing antibodies, vaccines, still part of the conversation. I think very important to be part of the conversation and to not leave adolescents and young people out of the conversation is remission and cure. And young people should be a part of all studies that are looking at these different strategies, including remission and cure strategies. Just to remind everybody where we started, we have pills. Adherence has been a challenge. Young people are asking for help. There are things that we like about our medicines and things that we hate about our medicines in terms of pills, and choice is critical. But biomedical is not all of it. We need to also be thinking about how do we improve our finding and targeting strategies to identify people who are at risk, to provide them with PrEP, as well as people who are positive, to provide them with treatment. What do the behavioral and community interventions that are needed look like? How do we optimize care models? Is it same-day start? Is it alternate venues for care delivery going to young people? Is it using technology, drones, other things? And how do we potentially get to personalized medicine where we can think about an individual and what may work best for them using all the different strategies and modalities. So with that, I'm going to stop and give a huge thank you for your attention. Thank you as many ways that I can think to say it. And thank you to the youth particularly who inspire me every day to continue to advocate and to push for what's best for them in both clinical care and research, and to the teams and the funders that make it possible.
Well, that was just awesome, Alison. Thank you, and a real pleasure. And it's lovely to see your face. Thank you so much for getting up so early. We know it's early over there in Baltimore. Alison, lots of questions coming in, lots of excitement, particularly about the 084 results. Thank you. I know those are hot off the press, so well done for including them in your talk. So Georgina asks, and I think probably rightly so, maybe it's about the time in the year, why hasn't there been more buzz about the 084 results given their implications for Africa?
Yeah, I don't know. This is the interesting thing. I don't know if it's COVID overload and it just has taken over everything, because the 083 results made a buzz, and so I'm not sure. I'd hate to say it has to do with women, so I won't say that. But I think it may be part of what's going on with the elections, et cetera, that it just may be overwhelmed by that. But I mean, very exciting, almost more exciting than 083, I would say. And so I think it's, I wanted to make sure I included it and keep talking about it. But yeah, I don't know, Georgina.
Sure. Somebody has asked, the big question about cost. I'm not sure if you're in a place to talk about that. Obviously, so important to adolescents. What are your thoughts about the cost and the implications?
Yeah, so I have not seen any good cost-effective analyses or modeling that I think would be really critically important in terms of the number of infections you avert, but which would afford the cost. Because I think that would be critical. I think certainly in 084 was done in the right place in terms of the number of infections we're seeing and the implications of so many young women acquiring infection. So I think, when it comes to costs, I often say we have to decide that it's worth it, right? We pay for things that we think are really critically important. And I think it's one that averting the cost of a lifetime of HIV should make this affordable to do and the right thing to do.
Right. So I should say to everyone, don't forget to post your questions in the question and answer. We do have Alison here, and she's an expert on hand to answer your questions. I'll pose one more, and Phyllis, you also be thinking of some. But I wanted to ask you, Alison, in your experience, what has been, your best tip that has really helped adherence to a daily pill, whether it be PrEP or treatment? What are some of the best things that you think have worked, particularly for young people?
Yeah, that's a great question. I think in starting medicine, even with all those choices, every regimen has their own side effects. And while a little bit of stomach upset may be fine for one person, it may be the end of it for the other. So I really spend a lot of time talking with young people about would this be okay? Would that be okay? And figuring out their lives and their schedule, et cetera. And then we make a decision together, right? So we come up with a decision together and a plan together about how to approach things if it doesn't work or if you develop things. I think that has been the joint decision making, where someone doesn't feel like you just wrote a pill and sent them out, but you engaged them in the process, has been very helpful. And then revisiting again and again and again. It's still working. My young people text me, Dr. A, I took my medicine, this happened, and being available to give them feedback, I think has probably been the critical thing.
Phyllis, I know you also help with young people adhering to medication. Any particular tips on your side or thoughts about that?
Okay, thank you so much. Linda, you were in my mind. I was about to ask the very same question to Dr. Alison, that then how the young people's, from her interaction, her preferences, and she's just alluded to that whatever it is, they have to sit down and plan together. As young people, yes, we know that we are so concerned about us and about our health. One thing we just hate is that you delegating, kind of giving a command that we should adhere and hence do A, B, C, and D. Let's sit together, hear what my schedule is like, because apart from living with HIV, I also have a life. I want to have fun. I want to go to school. I want to go to work. So what best can be done is you engaging us, then we discuss and we have a solid plan on adherence. So thank you so much. You're doing actually a great job. Thank you.
Well, thank you. I should add to that, never waving that finger. Oh, you were bad because that never works. It's like, all right, so we had a little hiccup. Let's think about what happened and how can we address in the future. Because if people feel bad when they tell you about being non-adherent, then guess what? They won't tell you about being non-adherent.
So one of the other questions here that I think is very real is both on the treatment and the prevention side, we've only seen data in the over 18s. What are the plans for people under 18?
That's a good question. My understanding, and Linda Gale, you may know this as well, but my understanding is that there is an adolescent trial plan led by Sybil Hosick, who also did the ATN 110 and 113 studies, because we cannot always just say it worked in adults so we can roll it down to adolescents. I think in research, we're trying to make those things happen together instead of doing one trial and then following up with the other, but there is an adolescent trial plan. I don't know how COVID has impacted the timeline for that, but there is one plan.
Yeah, I can add to that. Thanks, Alison. So it's called 0841. So it's part of 084. And Sybil is leading that, quite correct. And they're obviously going to have to modify a little bit in view of the fantastic results and make sure everybody's aware. But I'm sure that'll just encourage people to participate. And then on the treatment side, of course, there's a study called MOCA, which is ongoing at the moment. So you'll pick up a coffee theme here. There's latte, we haven't seen cappuccino yet, but there's mocha underway, and that's the adolescent one, and that's to try and work out the PK in people under sort of adult size, so that we can work out very carefully how to do the injectable treatment.
Yeah.
So
I was going to add to that. So MOCA definitely, we actually enrolled the first adolescent in the world on MOCA at Hopkins in Baltimore. There is also Plan 2022, which is very early, which is injectables for adolescents who have non-adherence. So following up with some of the study, there was one of the study in the adults, 85359, looking at adults who had non-adherence, but that was very challenging, the sort of the schedule they rolled out. You had to first adhere to pills for 6 months before you could be randomized for injection. And adolescents, it was hard, or young people 18 to 24, it was hard to get them to get on that study and stay on. So 2022 is planned, and hopefully we can get that going in 2021.
And we're very excited. We'll be looking at injectable treatment from a mobile. So to try and understand, can we give people shots on the trot, as it were, so that they don't even have to queue up at the clinic. And I know, Phyllis, you'll like that as a service delivery approach. So that will get going as soon as we get the first data out of MOCA, just so we can move out of the research environment into more of a life, living real world type of environment. So here's a great question for you, Alison. What about the side effects with injectable PrEP? Have we seen them? Is it a problem? How will we manage that? And that's from Irene.
Yeah. So to my understanding, the major side effects is because it's a shot in both sides of the bum, right? And the major side effects are injection site side effects, and not other ones specifically. So that's probably the main one. And initially there's high, and then the report of that being really debilitating or really concerning is less. So that's my experience for the young people that have had it.
Quite right. And even amongst our MSM community, where maybe the butt isn't quite as much, subcutaneous, even there, although it's been noted, and people have said there's been some pain, been incredible levels of tolerance and willingness to take the injectable. So it does look like benefits are outweighing the side effects at this point. Otherwise, it's a very easy drug to take. Just to remind everyone, it's a close cousin of the new treatment drug called dolutegravir, although it's not exactly the same, but similarly has very few side effects. So.
Exactly.
I'm seeing one here. What about risk disinhibition? So, or taking more risky behaviors, because now I've got a shot on board that's going to protect me for 2 months. What do you think about that, Alison?
So it is not so I have not seen any data that's looked at the risk inhibition related to the injectables. My response usually to that is, if someone says they are sexually active and you say, oh, well, I don't want to give you a birth control pill because then you'll have more sex and get pregnant. It seems counterintuitive. To me, I think we need to provide people with an armamentarium of things to keep them safe as they engage in sex. And if they have more sex, we'll provide them with tools to keep them healthy. But I don't use it as an argument to argue against it. It seems counterintuitive to me and counterproductive.
So there've been a couple of questions. I see Zuzu raising this, a few others. What are the next steps, Alison, in your opinion, in terms of both the treatment, which we've known for a little longer, and now the prevention aspects of the injectable? What needs to happen next and happen quickly?
Yeah, so it's a great question. I mean, I think both Linda and I have alluded to studies that are planned for, all right, so we are going to look at this in younger adolescents. We're going to talk about how to deliver this to people in the way that makes sense for them and their lives. Then it's going to be how is it going to be paid for? I think there's several, how does it then fall into the guidelines? Because we're starting to see things that are comparable in terms of the treatment for prevention. It's actually superior, right? So I think the data is superior. So I think it's going to be aligning all those things of just some of the questions that I laid out. I think there are some studies to be able to tease out the differences in the long tail we're seeing in females versus males, and how will there be different strategies for females versus males. I think there are lots of things to work out, but I think we're at the point that it's time to work those out, and not that we're back at, oh, should we do this or not? I think it's how do we do it, and how do we do it well?
So I'm going to take us back to daily pills, because that's sort of where we are at the moment, right? And Alison, I know it does come up, and it's sorting out that paradigm of PrEP we can take or leave, depending on our need. What about treatment? Just bring us up to date on what the thinking is around drug holidays, about time out on treatment. What is the latest thinking in that regard?
So in terms of, let me make sure I understand the question, Linda Gale, in terms of how we need to engage with treatment and whether treatment interruptions are acceptable or not. Is that the question?
Correct. Yes.
Yeah. So I think now that this definitely with data from years ago, we know that treatment interruptions are challenging and actually harmful potentially, with increased inflammation and increased risk of heart attacks, strokes, et cetera, when you stop your medicine. So the going strategy and what we think works best and data shows is that once you start medication, you continue your medication for life, right? And I think the challenge for you saying that to somebody who's 50 versus someone who's 20 is for life is a different period of time, which is why we're talking about that. And so I think there's certainly, I talked about trying to simplify treatment, trying to think about regimens that you can take and they last longer in your system. But the idea is that you continue that treatment. There is more conversation about cure and remission and how can we get people to there. And so while we're talking about prevention and treatment, there is also growing momentum around cure. And I have argued and for adolescents to continue to be part of that conversation about cure, including those who are perinatally acquired, where yes, we can do treatment, et cetera, but we also need to think about how those young people fit into the cure strategies. And let me add to that, while ART, I think I mentioned monoclonal antibodies and other strategies that are beyond ART. So I imagine a time frame where we'll be thinking, all right, here's this person who's been doing well in their medicine. Now they're going to college. They're going to travel abroad for a year. Let's try the shot. Let's to the ways that we can then design things that work for people's lives.
Yeah, it's obviously going to have implications on how we give these out. So,
Yes.
returning to the injectables for a moment compared to daily pills, what are some of the considerations around that? Have you given it much thought in terms of how you might, say, manage your clinic or distribute these medications?
Yeah, that's a great question. I think right now we know that the studies have been done first in people who are treatment naive, and then for those who are transitioning, people who are adherent to their medicine. So you have to have an undetectable viral load to have then been put on the injectable. So that's where the studies are starting. And so I've already for the last year and a half been having conversations with my patients about, is this something you would want? Because again, it's got to start there. I can't just dictate we're now moving everybody to injectables, because there's some people who don't want injectables. They're like, I'm fine on my pill, let's go here. But in terms of how it would roll out, currently they are being given in a medical setting, right? You talked about the mobile van going to people. Reality is sometimes people may not want to come to the mobile van because there's a concern about disclosure or stigma. So should these, I think, medicines be thought about eventually to be given at home? Can we get somebody their injectable to be given in the privacy of their own home to be able to continue? So I think we need to be thinking about how will not just we distribute it, but where would be distributed and who can give those shots, because ultimately that's how we're going to optimize adherence to the medications. So we've talked about for our own clinic, would we create infusion clinics where people come in, these times, and you can just come in and get your shot, right? While they're in clinical. But ultimately, I think it's how do we get to people being able to give them to themselves is where I would love to see this move over time.
So I think what we're hearing about, and I love this, is, getting more than one service in a place. So you'd get your STIs, your contraception, your treatment in one place. But ultimately, we are moving to designing interventions that actually incorporate the medications into one shot. So
Yes.
Talk in the last few minutes around multi-purpose technology and what that might hold for the future.
Yeah. So I think it's so exciting to hear, companies talk about how do we potentially, I think somebody mentioned in the chat, combine your injectable, your depot with your PrEP, or your birth control, your long acting, your in your arm with your implant for your prevention. And so there are conversations being had about how we can make these multi-purpose, you said, strategies to not just do one thing, but to do multiple things. And how do you match the duration? What will be important is matching how things are delivered, what's the duration of time they're in, to then not have one no longer be working and the other one be working. But I think those conversations are being had, which is exciting.
Indeed. So I think we are in the midst of a prevention revolution, and prevention's catching up to treatment in terms of how exciting that space has been. And so with that, Alison, I want to thank you for your terrific insights. We hope you'll stay with us.
Yes.
Because everybody right at the end will be, hopefully if there's time, bringing everybody back to have more of a discussion. So keep your questions flowing in the Q&A. And for now, we just want to inspire you all before we have a short break and then move into the very important oral abstract session, where you'll hear real and very fresh research data presented. I'm going to hand over to Phyllis to introduce to you a wonderful video just to get you all inspired about your pills, your injectables, and other interventions. I'm going to hand over to Phyllis to introduce the video.
Thank you so much. I wanted to listen to more and more and more of Alison, but without wasting much time, thank you, Linda. So the following video is going to be played. The song is called How to Dance, and following in the footsteps of a courageous woman who was the first Zimbabwean to speak out bravely about her HIV status in the 1980s. Africa Jandiri then won the Auxilia Chimsoro Alumni Award from PAPFER in January 2013. And children and adolescents from Jandiri used this award to follow in Auxilia's footsteps by also speaking through their own experiences and showcasing and thereby compiling a song on a DVD. It motivates and inspires actually that in the midst of all the challenges that we're facing, we don't have to wait for the challenges to end. But in the midst of those challenges, we're going to live our lives. We're going to go to school. We're going to pursue our dreams. We're going to have advance our career. So that's what the song is all about. So thank you so much. Enjoy.
Sticks and stones won't break my bones, break my blood, make me better. I'll take a pill, then take another. That won't bring back my love, yeah. Oh, my, what now?
Okay. A warm welcome to everyone. I hope you've enjoyed your break and let's get started. Special thanks to Alison for opening up the way, and thank you so much, Linda. It's so wonderful to be co-chairing with you on this wonderful session. I'm giving you a virtual hug. Okay, so I'll be introducing our first oral abstract presenter. Ladies and gentlemen, let me introduce you to our beautiful Alona Tosca from the University of Cape Town in South Africa. She'll be presenting an abstract 9 on the acceptability of long-acting injectable antiretroviral therapy among adolescents and young people living with HIV in South Africa, hence the missing link for the third 90. So Alona, over to you. We are waiting.
Hi, my name is Elona Tosca and I'm a researcher at the University of Cape Town, and today I'd like to present analysis from the Mzansi study in South Africa looking at preferences for long-acting injectable antiretroviral therapy among adolescents and young people living with HIV in our study. I'm presenting on behalf of a large team who I'd like to thank for their work in collecting this really large data set. Why did we do this research and analysis? We know that the health and well-being of the nearly over 2 million adolescents and young people living with HIV in sub-Saharan Africa is dependent on taking daily ART pills, whether single or multiple pill regimens. But we also know that adhering to retroviral therapy in adolescents and youth is quite hard, and sadly, non-adherence is linked to not doing well. Long-acting injectable antiretroviral therapy, which I'm going to refer to LAART for the rest of this presentation, if you see it in the slides, it has the potential to overcome some of the barriers that shape adherence to and non-adherence to pill-based ART regimens. But the majority of the research on this mode of ART is actually primarily focused on PrEP rather than treatment. So in the third wave of the Mzansi study, so we interviewed our adolescents and young people 3 times, as you can see here, over a 5-year period. We actually added a question about their preferences. If they had a choice, how would they receive their antiretroviral therapy? And this is the data that we're looking at today. We were very lucky that we followed our young people, and the young people were eager to participate in the study at high rates. We're able to follow up with nearly 97% of them, though sadly, in the duration of these 5 years, 3.4% of them were confirmed to have passed away. Who ended up being included in the analysis? We analyzed data from nearly 950 adolescents who were over 2/3 more than 15 years old at the time, just over half female, a quarter lived in rural communities, 1 in 5, 1 in 6 lived in informal housing. We observed they live in resource-poor communities with homes that were missing. 2/3 of the homes were missing at least one basic necessity, and high rates of orphanhood. Over 3/4 were vertically infected, and a small proportion, 1 in 10, were recently initiated on ART. We looked at the literature, but also at qualitative work from our team in the Mzansi study. What could shape the most, that was treatment-related factors that could shape the most preferring injectables over pills. And we came up with this list of factors that we later tested. We discussed with colleagues in the field, and we designed a simple question to test preference for ART delivery mode, keeping in mind that the adolescents and young people in our study had not been exposed to many other modalities of ART. Though the young women in the study would have been exposed to injectables and implanon potentially, and maybe even rarely vaginal rings and products such as the IUD through family planning. We asked, researchers are developing many different types of medicine. If you had a choice, how would you prefer to take your ARVs or HIV medicine? And these were the options that we offered them. And this is what the adolescents and young people in our sample told us. As you can see in purple and in black, so 86% preferred pills, and this is perhaps not surprising because they may have been taking them for a long time and are familiar with them. But then we look in the circle there, that's the gray and the orange slices, totaling 12% preferred injectables either every 3 months or monthly. And it is these 12% that we compared to the 86% that preferred pills to see who were the adolescents who preferred injectables over pills. And if you remember the list of factors that we saw in the earlier slides, we actually found no difference by all of the factors listed here. So we didn't see a difference by age, whether they lived in a rural community, in informal housing, poverty, or if they were orphans, by mode of infection or mode of HIV acquisition, whether they were recently initiated on ART, whether they had a treatment buddy or attended a support group. We didn't see differences in preferring injectables over pills if they found it hard to take pills around a partner, or if they had struggled with taking a lot of pills recently, nor by retention and care and recent disclosure or learning of HIV. What made a difference was being male. So male participants were 33% more likely to prefer injectables. Those who had changed medications in the last year were 57% more likely to prefer injectables compared to pills. Those who had experienced hunger in the last week were 73% more likely. And perhaps unsurprisingly, those who had experienced medication side effects in the last year would prefer injectables over pills, and those that experienced stockouts were 120% more likely to prefer injectable ART to pills. What we see here is that individually each of these factors was linked with preferring long-acting injectable ARTs, between 6 and 12%. But adolescents and young people who had experienced all of these factors, so who had had medications changed in the last year, who were in a household that was food insecure, where they're experiencing hunger, who had side effects, but also had not been able to pick up their medications in the last year, 1 in 2 of them would prefer injectables over antiretroviral therapy. And this is really interesting to us because, as we said in the title of our abstract, it's important for us to think, now that we have evidence and working formulations for PrEP, it may be worth considering how we can make this long-acting injectable antiretroviral therapy to those adolescents and young people who really struggle to take pills. And we have here some data on who those adolescents and young people are, and they're really, and it's really strong. We could really support at least half of them to actually be able to perhaps adhere better and have better health outcomes. I'd like to thank our team who did all of this. If you find any errors, they're all mine, and the amazing work is all of the colleagues named and pictured here. And a thank you to our funders and to all of you for listening.
To a brilliant talk there, Lona. Wonderful job. Phyllis and I will now ask you a few questions. We're inviting the audience, of course, to submit their questions in the Q&A. Don't forget to do that, everyone. We'll continue to field your questions and make sure that we can continue to answer what I think is becoming a really interesting theme this afternoon of, pills versus injectables. But Ilona, essentially it's not pills versus, but pills and injectables, isn't it? So although the kids in the cohort, favored injectables, what is your thinking of how we will position these kinds of treatments going forward?
Thank you, Linda, Gail, and Phyllis. Really wonderful session so far. I think that's exactly why we posed it as a question at the end of our title. And we said, is this the missing link or a possible link to meeting the last 90? Because it is through a combination of options. And it speaks to the differentiated care that you mentioned earlier approach, and how can we actually reach those who are currently not happy with taking pills. And this is very early analysis, it's cross-sectional, so I don't want to assume that it's answered all the questions, but it was interesting to me, for example, that male participants specifically were more interested in injectables, and we know that it's harder to keep young men engaged, so that's quite promising. Now, I know, of course, that there's also lots of cultural experiences and understanding of injectables, so we'd have to obviously think about that a bit more and contextualize it. So I don't want to say that all men will suddenly now flock to the injectables, but I think thinking about how do we segment who is taking ART for life, and how do we offer the products to match lifestyle and age and stage is quite important. And to acknowledge, that side effects, for example, are a real burden, and issues like hunger. So, not to make it to label it poverty, but it is a big deal. If you don't have enough food to eat, it's harder to take your pills, and maybe it makes an injectable more acceptable and promising.
Yeah, I couldn't agree more. There's a question here. Maybe you can expand a little bit, even outside of the data you showed us. Why do you think men or boys thought the injectable was the answer? What might have driven that decision?
So I may be pulling in here from other works. I must acknowledge that there's a few other colleagues who have shared this with, who have helped develop some of this thinking, some of these answers. But young men are less likely to initiate and remain in care for a variety of reasons. There's, as we know, norms of masculinity, but there's also how they are displayed. So physically going into a clinic is not common. It's usually, women who are regularly engaged because of all of our public health system setup. So an injectable that is quite more spread out is more attractive potentially, because it allows one to be who they think they are and present themselves in the world in that way. It's also possible that it is logistically easier to do, rather than have to carry pills, and men are often more likely to be formally employed, especially young men, and be out and about, rather than women, in our communities that may be more homebound and in caring arrangements, even informal. So those are two of the more immediate ones that I would think of, but I'd really love to hear from others as well.
Well, it occurs to me to ask Phyllis, in your experience in this Vandiri model, do you find a difference between men and women, or boys and girls, in this regard? Is that something we see in Zim as well?
Yeah, I'd like to say it's a similar situation, where I feel that with the coming in of the injectables, they'll help curb that problem of where our males have that low health seeking behavior. They always want to be kind of private, should I say it. So when it comes, and I was also thinking about also the distribution models. Again, it will be much more also greater that it limits their time to go to the health facility, and even if they can arrange it to have the injectables at home, it's something that will promote adherence amongst young boys and men who are on treatment. So I'd really love the idea of the injectables.
And Ilona, let me ask you the following question. This Mzansi Waka has been a phenomenal project, and congratulations to you, Lucy, and everyone. How do you think this kind of work helps us? Because this was a former question. How do we get this data into policy? How can you, how do you use what we've learned this afternoon to get things moving?
Thank you, Linda Gale. And that's true. This is not an intervention. I mean, I'd love to have given it a coffee-related name, because I really love that. But it's really, we didn't provide a service. It was a hypothetical question. But because our goal has been to observe how young people grow over time, that is our contribution. Already presenting it in a space like this and pushing the conversation, that's how we're hoping to do it, but also sharing it through spaces. For example, in South Africa, the South African National AIDS Council prevention task team. I think there is a lot more that we could do in reflecting how we engage with our young people living with HIV in the prevention cycle. I know that it's been called many different things, positive prevention, lots of different phrases, but I think a lot of us who work on the prevention side, I mean, not you, Linda, Gail, and Phyllis, you take a very holistic view, but we stop sometimes. And Alison's presentation was amazing because it covered it all, but we often are very siloed. So I think a lot of my work has tried to link it together in a cycle. And actually, I only did this analysis, I must say, it's not my area, but when I saw the PrEP data come out this time, and I thought, let me just rush and do this. We have this question, let's see what it tells us. And it's to just add another voice from South Africa to the push. And Georgina, your point earlier was super valid. We need more noise about this. And I'm hoping young people can take this data and say, look, this is the voice of 1,000 adolescents in South Africa. They want it, I want it. These are the ones who are struggling for these reasons. I'm struggling for that reason. Make this available to me. I'm very happy for it to be used as is helpful.
Thanks, Ilona. And I think to Phyllis's point as well, particularly if it can reach young men, where I think we have a gap in our programming at the moment. That's very exciting and potentially important. So, thanks for that really important work. We're going to move on to our second oral abstract of the afternoon. Hang in there. We have some more videos coming for you later. So those of you who love to watch YouTubes and videos, hang in there. But before that, it's my great pleasure to bring the second oral abstract, again from Zimbabwe. And in place of Dominica Dakwa, we want to thank Fungai Mzengerera, who stepped in to present PrEP uptake among adolescent girls and young women enrolled under the DREAMS program in Zimbabwe. And so without further ado, I'm going to ask Fungai to step in and give us this abstract. Thanks.
Thank you very much for the kind introductions. So today, we are honored to be invited to present a study that we undertook on uptake of pre-exposure prophylaxis amongst adolescent girls and young women who are enrolled into the DREAMS program in Zimbabwe. The DREAMS program is a USAID PEPFAR supported program. This is an HIV program that is an HIV prevention program that is targeted at reducing new HIV infections amongst adolescent girls and young women. The DREAMS program, which is an evidence-based program, is responding directly to evidence on increasing HIV infection amongst adolescent girls and young women. If we look at data in Southern Africa or in Africa in general, and in Zimbabwe in particular, there is evidence of age and gender disparity in HIV infection, with adolescent girls and young women disproportionately affected by HIV relative to their male counterparts. And GBV is at the center of driving HIV infection amongst the adolescent girls and young women, with 1 in 3 women having experienced GBV in their lives. So pre-exposure prophylaxis, PrEP, provides protection to anyone who is at high risk of contracting HIV from contracting HIV. And therefore, because the DREAMS program is an HIV prevention program, this PrEP presents a window of opportunity for us to support adolescent girls and young women from acquiring HIV infection. The DREAMS program provides a comprehensive evidence-based core package of services that go beyond the biomedical to address the social, cultural, and structural barriers to HIV infection. The DREAMS program core package of services provides services from provision of adolescent-friendly sexual reproductive health and biomedical interventions for male partners of adolescent girls and young women, to addressing social protection issues for the vulnerable adolescent girls and young women, as well as engaging the parents, guardians, and communities where the girls are coming from, in order to address the community and social and gender norms that put adolescent girls and young women at risk of HIV infection. And this evidence-based core package is provided in a layered approach, which entails that we intervene, we reach each and every one of our clients with a multiplicity of services to address the multifaceted challenges that they face in their lives. So in this study, we aimed to assess PrEP uptake amongst adolescent girls and young women. And in terms of our objectives, we wanted to determine the knowledge level on PrEP, as well as to establish what the uptake was amongst our target group, and also to understand what the barriers to uptake of services was. This was a cross-sectional study, and participants were selected from 4 priority high HIV burden districts in Zimbabwe. We applied a mixed method approach, and primary data was collected through in-depth interviews. We also used the structured questionnaires to complement data collection. We analyzed the data through SPSS version 2.2. In terms of results, what we established is that 56.8% of the adolescent girls and young women who participated, they were very knowledgeable about PrEP and the way they could obtain PrEP services in their areas. A small proportion of about 6% had accessed the PrEP within the last 6 months, and 68% of our participants were single, with 17% married, and 13% were divorced. 55% of these girls and young women were very satisfied with using PrEP. But amongst the barriers to uptake of PrEP was the issue of seeking consent or seeking approval or permission from their sexual partners or another third party. Girls could not make a decision whether to enroll on PrEP without consulting these significant others. And 43% of the adolescents did not have adequate knowledge of PrEP. 24% were not decided whether they should be enrolling on PrEP or not. In terms of the conclusions, because PrEP is one of the evidence-based strategies that we have for HIV prevention, we are recommending that PrEP be scaled up to all districts so that adolescent girls and young women can easily access it and prevent HIV in their lives. Thank you.
Well, great. That was Dominica Dakwa, and thanks very much to her. I'm sorry she couldn't be with us this afternoon, but that was very clear and comprehensive. In her place, we welcome Fungai. Thank you so much for joining us this afternoon, Fungai, standing in there just to answer a few questions. So I think striking from that description, and something we've seen all throughout Eastern and Southern Africa, has been somewhat of a slow uptake of PrEP. And I think, you know, again, your data shows that this is due to a lack of knowledge and awareness amongst young people. Do you think that's been improving since this study was done? Are we doing enough? What else could we be doing in this regard?
Oh, thank you, Linda, for the question. So under the DREAMS program, interventions have been done. So there have been sensitizations which were being done in the community for the adolescents, girls, and young women. There's been some trainings on PrEP presentation from facility health workers on the PrEP uptake, as well as the advantages, as well as the disadvantages of PrEP. So however, from the sensitization meetings which were done, adolescent girls and young women actually showed an interest in taking up PrEP, and also there's been an increase from the time we conducted the study to date. Thank you.
Do you think there's more that could be done in the region? Are we, and now I'm sort of asking you to take the 20,000-mile view. What do you, in your estimation, what do you think needs to be done in this region about trying to get PrEP scaled up?
Oh, thank you. So for the region, since this is a policy issue from the studies which we conducted, as well as also the programming, the interventions, we also submit our reports to the Ministry of Health and Childcare, to our funders who are USAID, as well as the stakeholders in the communities where we are actually implementing programs such as the PrEP. So from that as well, we are actually lobbying to make sure that PrEP is actually spread throughout the region, throughout the country, and in all the corners where adolescent girls and young women are, so that actually we try to reduce the impact of the HIV burden among this age group. Thank you.
Thank you. Thanks, Fungai. Phyllis, I'm going to ask you, sorry to put you on the spot again, you're my captive audience here. So one thing we do have a lot of presence on the, in the region are young people living with HIV, advocating for treatment. Do you see a role for those networks in trying to get prevention and something like PrEP, scaled up? What role do you think young people, young organizations, grassroots organizations can do in this regard?
Okay, so thank you so much. Maybe what I can say is that, also taking from my experience, because I've been a Heifer Dreams ambassador before I turned 24. Yes, so we actually do have a major role in advocacy, in that, PrEP is more on the prevention side, and looking at the HIV burden, we need to increase actually access to PrEP. And also something that was coming in my mind during Dominica's presentation on, yes, the PrEP uptake has been slow actually, but now with coming with the intervention of injections, I would also want to pose it again back to Fungai that we know that in the African context, there's more of like seeking consent, the in-laws, their husbands, how the African society is also built. And where do you see us or with the coming in of the injectables? And also actually that will help us in also our advocacy, coming in with the injectables. Is it going to ease the challenges that the adolescent girls and young women have been facing? Is it something that we should really go strong and advocate for, so that we have more access to uptake of PrEP? Thank you.
So Fungai, I think that question is posed to you. I think it's a great question. What role, or how do you see injectable PrEP improving the situation that you've presented now in the DREAMS program? Do you think, long-acting cabotegravir could change how young women perceive PrEP, given that it's a daily intervention at the moment?
Oh, yes, thank you for the question. Since the DREAMS is a consortium of partners, we work hand in glove with other partners. So through the efforts of actually referring clients as well as adolescent girls and young women from one partner to another, as well as the use of injectables, there's been a positive uptake. And I assure you that the increase is actually noticeable. And from the time we conducted this study, I think there had been an uprise in the uptake of PrEP. So the use of injectable, I think it's a good idea and it will be acceptable by the adolescent girls and young women. And as Phyllis has just indicated that this is a policy issue whereby there is also need to lobby with government institutions, private players, as well as the community leadership and the adolescent girls and young women as well. So the uptake, it will actually be positive. And as an organization, we will continue to lobby as well as to disseminate the information so that it will actually benefit the communities.
So Fungai, nice question here from Georgina. Those, young people's lives often don't accommodate a daily pill every day, and remembering that. What do you think are the characteristics of the young women and girls who were able to adhere well to daily PrEP? What kind of person is that, in your opinion?
Okay, so the young women, most of them whom we reached, they are in sexual relationships with older people. Some of them truck drivers, and some of them they are not in a position to negotiate for safe sex. So those are some of the highly vulnerable groups whom we encountered whilst we were doing programming as well as conducting this study. So in terms of reaching them, actually, it's mobilization through the community cadres. We work with partners as well as community cadres who actually do the mobilization, who actually meet the adolescent girls and young women in their communities. And hence, that's how we identify them so that we actually put them on PrEP. Thank you.
I'm going to send one last one to your, it's my own contentious one here that Irene raises. Are you advocating condoms together with PrEP? What's your message around condoms and PrEP in your program?
Okay, thank you, Linda. So it's a comprehensive package which we actually give to the adolescent girls and young women. So we do not advocate for PrEP only, but for preventive measures. We advocate for all the methods, which in the end will make sure that the adolescent girls and young women are safe. So besides PrEP, we also advocate for condoms, both male and female condom trainings are being done on condom use. And also in one of our studies which we conducted, condom uptake as part of the family planning methods also peaked from the previous year, showing that the adolescent girls and young women, they are also going for condom use as part of a family planning method as well as preventing from HIV. So we are actually consolidating all the methods to make sure that the adolescent girls and young women are actually safe. Thank you.
Thanks, great answer, Fungai, and thank you for presenting the questions and answers section for Dominic. Please send our thanks to her as well, and please hang around. I see still many questions coming in, and we'll circle back again in a moment if we have sufficient time at the end. At this moment now, just as an interlude, we're going to introduce to you a video that was created down here in the Cape with that intention to see if we could increase demand. And what I want to tell you is that this was devised by young people themselves. These are not actors, these are young people from the community who took part in the video. And really just to give you a sense of what we can be doing to create demand around pre-exposure prophylaxis. So sit back and watch this short video. Enjoy.
I have big dreams and bigger plans. I'm prepared for life's twists and turns.
I'm in control.
PrEP is a new pill you take every day to stay HIV negative. Andiqinisekanga nokuba ndim ndedwa na kwiqabane lam.
It's like a pregnancy prevention pill. If you take it every day, you won't fall pregnant. And if you take PrEP every day, you won't catch HIV.
If I've been taking it, I know I'm protected.
Indenza ndizive ndikhuselekile.
I'm looking out for my future.
Ndiyithatha nsuku zonke kodwa ayingumthwalo inxalenye yobomi bakho.
I use it because I want to be in control.
So Phyllis, I'm going to hand over to you for our last oral abstract of the afternoon.
Okay, thank you so much. I loved the video. I love the key take-home message that I got there, that if it's like a pregnancy prevention pill, if you take it every day, you won't get pregnant. And hence, if you take your PrEP every day, you won't get infected. That was a great video. Thank you so much for sharing. So allow me to introduce to you to our last oral abstract presenter. We have Jeffrey from Grassroots Soccer in the US, who will be presenting on abstract 59, better, cheaper, more effective using a rapid cycle improvement model to improve implementation and outcomes on sport-based VMMC demand creation in Zimbabwe. Over to you, Jeff. Thank you.
Thank you for joining us. My name is Jeff DeSells from Grassroots Soccer, and I'm representing Begampilo Moyo and a study team from Grassroots Soccer for our work in Zimbabwe called Better, Cheaper, and More Effective, using a rapid cycle improvement model to improve implementation and outcomes on sport-based voluntary medical male circumcision demand creation in Zimbabwe. So a bit of background, Grassroots Soccer is an adolescent health organization that uses soccer or football to reach young people. And we developed a once-off intervention, or what we call a practice, to increase demand for circumcision. And in that once-off session, we have a fun, interactive educational game where the boys, or the participants are playing soccer and learning about circumcision. And that's followed by a personal story from their coach, who's generally a circumcised male who can talk about his experience. And then a group discussion where the boys can ask questions and really learn kind of the answers to what motivates them. Following that once-off session, the coach then offers to accompany the participants to the clinic to undergo circumcision. And in Zimbabwe, we've run 2 randomized controlled trials, one with adult men and one with adolescent boys, and both showed very encouraging evidence of demand creation. So after those randomized controlled trials, we really wanted to implement and scale in a real world setting. So we fortunately had the opportunity with USAID's Going the Last Mile to partner with Population Services International, PSI, to implement Make the Cut in both Bulawayo and Harare, working with adolescent boys and young men ages 15 to 29. And what we wanted to do, we didn't want to conduct another randomized control trial. We really wanted to see what worked and what didn't work in implementation. So we applied what's called a rapid cycle improvement model, where we would review monthly along with PSI. We'd look at routine monitoring data and observations to see what was working, what wasn't, and to quickly correct and try to make data-based decisions. So what we looked at monthly was total VMMC uptake amongst our participants, how many were getting circumcised. the conversion rate, which is the number of circumcised participants divided by the total participants, cost effectiveness, which is a rough calculation of what it would cost to get a male circumcised, and observations from site staff. So that included our coaches who were implementing demand creation, as well as representatives from PSI who were observing service delivery. And over the 6 months of data collection, we learned some interesting things. So from the first month to the last month, we saw an increase of VMMCs, about 23% increase from 484 to 596, which is encouraging. We saw an increase in the conversion rate. So the rate increased by about 184%, which was encouraging. We saw a slight increase in cost per VMMC generated. So we would have liked to see that go down. So hopefully we'd be getting cheaper over time, but it did increase slightly. And just to note, I think if the program would have gone on further, we probably would have seen that number come down because a lot of the fixed costs were upfront. So the training, some of the materials we had to buy, so that would have gone down gradually. But it did increase, and it's something to work on. And this figure shows a few of those indicators over time. You'll notice there is a dip in December, which is very common in VMMC programs to see a dip around the holidays and during the summer months. So not surprising. We would have loved to see a clean line keeping going up, but not surprising. Some of the innovations that we tried, so we would meet monthly, look at the data, and then try out some solutions. Some of what we tried that worked was introduction of female mobilizers. So when our numbers were initially lower than we expected, we saw some evidence from the field that female mobilizers can be as effective as male mobilizers, if not more so. And we tried that out, and it was very effective. We also brought both the VMMC demand creation and the service to men at the workplace after hours. So we were having difficulty reaching men as opposed to boys, which we were able to get somewhat easily through schools. We found that bringing the service and the demand creation at once to men at the workplace was more effective. And then an observation we had that we continually worked on was just improved communication between the outreach workers and the clinicians. So the clinicians would know when we were bringing people to get circumcised, what messaging we were providing, and just always that need to improve communication. So this was our first time using the RCI meetings, and we found them really valuable. Something we'd like to continue doing. Because we were able to not just collect data for publication, but to actually use it. And the next steps, because we have all these data, we're going to be able to disaggregate it and learn more. We'll be able to take the data for what worked and what didn't work for adult men versus boys. We'll also be able to look at the differences between Bulawayo and Harare, which are quite different. So we'll be looking at that. And we'd like to share the Make the Cut curriculum and kind of this process we used for making improvements more widely, because we think it could be quite valuable for anyone implementing VMMC programming. Thank you very much.
Great. Well, thanks so much, Jeff. I think you might be asking why we had VMMC in the middle of a pills and injectable session, but I think the important message here is that we didn't want to give the impression that treatment and prevention only consists of pills and injections. There are other important tools in the toolbox, and this is one of them. And then I think we were just really impressed in this kind of iterative way to improve programs. I think there are a lot of important lessons to be learned there. So thanks so much, Jeff. I'm going to remind everyone again to put your questions into the Q&A box so that we can pose them to Jeff. But really, first of all, just to ask Jeff if you would expand a little bit on, I think the other principle. Let me back up. The other principle that I think this illustrates is too often we say, here's something for men, we're just going to focus on men, or here's something for women, we're just going to focus on women. And of course, in many cases, we need to get the whole, the whole of community around this. So just expand a little bit on the role that that women played in that improvement. What actually did they do, and how did you engage them?
Great. So I think the role of women, we found in the RCTs, we did a process evaluation along with the RCTs. We found that women played such a key role at several levels in the stages to undergo circumcision. The first is that it seemed to be that major conversation that kind of helped determine if a boy or a man was going to go, was that conversation with a woman in their lives. For boys, it tended to be their grandmother or sometimes their mother, and with the adult men, it was a girlfriend, wife, and so that was key. So we started thinking like, okay, how do we engage women, but we also want to have something that's really scalable, like a 45-minute session. We always wanted to have scale in mind. And then we saw some research and had some conversations with CHAPS and some other groups that have done a great job with VMMC uptake, and saw that they used, instead of the male circumcision, the circumcised male facilitators only to talk about their experience, actually having women, and they talk about their experience with the men in their lives and how they experienced circumcision. So yeah, so we just tried out training female mobilizers like male mobilizers, and it was really encouraging to see. There seemed to be, like, when we did observation, there seemed to be I don't know, just a bit more comfort in talking to women. There's I can't really explain why. I'd love to disaggregate the data more, because we don't know the uptake versus female mobilizers versus male mobilizers, but we know there's certainly a role. So I mean, maybe the ideal setup is a male paired with a female. So for the participants, if they're more comfortable talking about a male or a female, you kind of have both experiences. So we still have a lot to learn there for sure.
Sorry, great. There was a question on the age of the mobilizers. Maybe you sort of alluded to it, but maybe just expand on that. But let me ask this question, a vexed one, because I know we struggle with this in the Western Cape as well. Any cultural sort of barriers, key considerations as part of this, and how did you manage those, or work around?
Yeah, it's such an important consideration. So we did these randomized control trials in Zimbabwe. We've since expanded, I think, to about 9 countries, and it varies greatly. So for example, in Zimbabwe, where we've experimented with female mobilizers, and it seems to work great. There's not too much cultural circumcision practice in Zimbabwe. So there's not taboo or stigma related. Women can talk about it. When we first looked into implementation in South Africa, in Western Cape, where cultural circumcision is practiced, they said, if we implement this, if we have women going into schools and talking about circumcision, people could get attacked. It's that serious. So in some places we just can't do this intervention. But then in everywhere we go, we try to have what we call a curriculum development workshop to really understand the context. So if we're up in Uganda or Rwanda, you don't talk about circumcision the way you do in Zimbabwe. So as much as we want it to be scalable in 45-minute sessions, we realize we can't just put it in a box and send it to the 14 VMMC priority countries.
Correct. Yeah, I think that's really important. Okay, I'm seeing lots of interest in the female mobilizers. I think that's so. What I mean, using this methodology to improve outcomes. What are the sort of key lessons or take homes about what to watch out about? What to be careful of when you use this kind of methodology.
Yeah, great question. I think just I think what works is just the mix of inputs. So looking at these data points, but also the observations from our coaches, from the clinic staff, because a number could be telling you go to one way, but then what is actually happening in the clinic. So I think what helps is just having that rich dialogue of looking at the data, but also having those voices and really genuinely engaging what we call our coaches. Sometimes data collection can just be throwing numbers into a black hole, but actually saying, no, your observations are just as valuable as cost effectiveness, and it's what you see is kind of the most important thing. So I think, when you see suggestions that align with the numbers, that align with the observations, you can get some really, really innovative solutions. And just one other suggestion is just, we should try to have fun with it. And just be curious and playful, and realizing that the data is imperfect, and we meet monthly and say, here's something, and we may try to increase by going up here, and it goes down, so we try something new. So really just trying to be playful and curious, and if we can fit within the budget and try new things, just to go for it.
Great. Thanks, Jeff. I'm going to ask everyone else to turn on their cameras now, and we'll reopen a discussion opportunity here. So I think there was a question I could throw your way, Alison, from much earlier on. And maybe if we can keep our remarks short, because we are now moving into the last few minutes. Alison, there was a question about moving between injectables and pills, both in treatment and pre-exposure prophylaxis. Do you want to, I know we haven't had much experience, but do you want to just talk about whether that's possible, feasible? Can that happen for an individual?
So yes, I mean, I think the easy answer is yes. All the studies, people ended up transitioning for whatever reason, and at the end of the studies, people transition everybody to oral. So yes, you just, as your levels are going down, you then, start the oral regimen and just keep going. So there's no such thing as you're on injectables and you're committed to it forever. You can switch back and forth.
Ilona, I know you also love data. What did you find interesting around Jeff's kind of iterative performance improvement process? Anything you want to remark about there? Let me put this question, and maybe Jeff also has some ideas. Is there a danger in sort of changing too much too quickly? That would be one concept.
It's a great question, Linda Gale. I am not an interventionist, so I've never run an RCT, and I never will. Probably it's my commitment, partly because I think that being flexible, and I'm a social scientist, and partly because I think that being flexible in how we address, is key. I do think that bringing this conversation, I used to do M&E before I became a researcher, so I can see how they're linked very beautifully together. And I think we should be linking them, and bringing that sort of data into what is a conference or a research-like setting is really important, because we often operate in such separate silos where we sort of think it's only my perfect cohort study that took $2 million and 5 years to do, because it costs money to do research and trials. I mean, the development of the injectables, for example, have taken forever and a lot of resources, and how to build that continuum and learning iteratively. I thought that was really powerful. And I think to build that methodologically. So I think, thank you, Jeff. We've communicated by email. Great to see you live. But that was what struck me, how wonderful it is to see the continuum actually from the trial to the real life, even though of different methods.
Jeff, do you want to just add a word to that? The sort of being careful not to sort of go off in every direction, maybe if others are watching.
Yeah, absolutely, and it's something we struggle with. But we did know through those RCTs what was really influential in getting a guy circumcised, whether it was an adult male or whether it was a boy. It was that relationship with the coach. So we wanted to make sure that was always there, and also just realizing we can't do everything. Like we are grassroots soccer. So people ask, well, what about people that are not that into soccer? Can you do an art project? Can you do like all these different things, and we say that is great, we want to support that, but we are grassroots soccer, and you know, it has to be somewhat centered around sport. And also, like, you know, we have so many ideas about how to engage female partners, how to better engage schools. So it's always a struggle. How do we go big enough, but without going kind of too big? So I wish I had an easy answer. It's something we're always struggling with and trying to get better at.
Great. So I'm going to, in the last few minutes, ask each of you what the take home was that you got out of this session this afternoon. I'm going to start with you, Phyllis, because I think it's important to hear from our moderators as well. What was the big take home that you got out of the session this afternoon?
Thank you so much. I don't know if I still have much time, but I was very eager to ask Alison something. I wanted to ask her that, you know, with the injectables, right? I want to understand that they're also coming in to ease the burden on the healthcare workers, depending on their administration. But I also wanted to know that on the how far or how close or how far are we in terms of having the injectables being dispersed to individuals, like in the case of those who are diabetic and they're injecting themselves, and also maybe what we need to prepare for, as in how we're going to be taught to inject ourselves and all that, because there's a lot of questions running in my mind how this can be rolled out. I know it's too much for you, but maybe from what you've seen, what can you, it's just your own opinion.
Yeah.
Thank you.
No, I think it's a great question, and you're ahead of the game, and part of, and you should be asking those questions as we think how it lays out. I think certainly right now, the way I've heard about them being rolled out is all administered in the healthcare system. But down the line, it's sort of, how do we make it easier, if possible, to be administered in the field or at home with auto injections like they have for diabetics, where the pen that is filled, and potential other strategies. So these are all questions that are being sort of thought through and how. So you're asking the right one, and pushing, and I think that's important. So yes.
Okay, thank you so much. Okay, so from all the presentations, I'd like to sum them up, and I'm really impressed by where we are going in terms of HIV prevention, treatment, care, and support. And thumbs up to you, Jeffrey. I didn't know that it was a great initiative actually for having to disseminate such information, and like having to organize people in the traditional way where the males have to sit down and you start mobilizing. You did it in a more interactive way. Thank you so much. And from what I see, it's a big plus on our differentiated service delivery. What I love about the coming in of the injectables is that we're not going to phase out the pills, but what researchers are more creating possible ways to promote adherence, because from what I understood is not everyone, people are not going to be forced actually to transition from the pills to the injectables. It's just increasing more ways which people are comfortable with, and scaling up the uptake of treatment, and also thereby promoting adherence. So thumbs up. Thank you so much. I'm really looking forward to seeing it cascade down into our countries for everyone. Thank you so much.
Well done, Phyllis. Thanks. Ilona, thoughts from your side? Did you learn anything?
I mean, I loved seeing how my work fit in the context of everyone else. So thank you, Alison, and everyone through your questions. And I think it convinced me that we should be a bit louder. Phyllis, your question about how do we roll this out means that it has to be, made into different mechanisms of delivery, which means more research, more development, more money. So that we should try and get this out there, that young people want these different products, and that we need to develop them and to keep talking to them. Thank you.
Jeff?
Yeah, I was just so impressed with all the presentations, and I think what came through was just this very honest respect for adolescents. We know as adults we don't want to be told what to do. We want to be given options, And I forget who said it, but not enough just to say, take your pills, or go get your shots. We don't want to be talked to like that, and adolescents don't want to be talked to like that. So that respect is so important, and it came to the presentation. And the other thing I would just like to elaborate more, it all seems like all these experiences building positive experience with healthcare system, positive experience getting switched sides, you're more positive experience with PrEP or ART. So everything we're doing is creating that positive experience. So, just an honor to be part of this panel, so thank you so much.
Thanks, Jeff. And I'm going to give the last word to Alison. If you can round us out, having started us off.
Sure. So I think, and there's a bit of noise, I'm not sure if people can hear me, but I will say we started with the continuity. And I think continuity takes creativity, context, and choice. And so if we have to sum it up, that's what I would say.
And beautiful note to summing that up for us. Thank you. Choice, I think, one of the big C's. At the moment, I will remind everyone we have to worry about the other 3 C's: close space, close encounters, and crowded rooms. So remember that, everyone. But I also like the C for choice here. So well done, Alison. I think that's really great. I want to thank Phyllis for being a most magnificent co-moderator, as always. I'm returning that virtual hug and wishing you well, Phyllis, in Zim. Lots and lots of love. I see your hand up. Do you want to have a last word?
Sorry about that. I would already posed my question. Thank you so much. Sorry.
Very good. I'm slow to see the hand. Thank you very much. Okay, and so in the last few minutes, I just want to move on to thanking our sponsors, of course, of the HIV Adolescence Month. And there you see them, wonderful as they are. Thank you to each one of them for the contribution. I'm going to remind you, please, to join Zuzu, Sadie, and Caroline at our next session on Thursday. It really promises to be very exciting about treatment, care, and support and living with HIV. And it's a terrific lineup, and I'm almost convinced that things are just going to get better and better. Not to forget the skills building sessions. Please pitch up, please pitch in. The skills building sessions are always much enjoyed and a lot of fun, but you also get to learn a lot. So thank you for that. And last but not least, I want to thank Karen and Rika and the team for putting all of this together, being in the background, just working in the most extraordinary way. Thanks to them. And finally, now you move straight to poster viewing. Go and enjoy the posters. You'll be hearing live from people who have data to show you. Let's support each other. Let's get the word out there, and let's really enjoy the rest of the HIV and Adolescence Month. Thanks to everyone.
Indeed. your broken past. Broken. Learn to be ashamed